Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology, welcoming you back for my first interview of 2025. And I hope for those people not in the north that they're having good weather. Today I'll be speaking with Doctors Rashmi, Dhital, and Christina Chambers, who are the first and senior authors, respectively, of our featured article titled Cardiovascular Events During Pregnancy, Implications for Adverse Pregnancy Outcomes in Individuals with Autoimmune and Rheumatic Diseases. I want to thank you both for taking the time to speak to me and our listeners on behalf of all the authors of your paper, and hope we have a good discussion about your findings. So with that, we'll start, if that's all right. Okay.
Yes, thank you.
I wonder if you could give us just a little background to the previous work that's been done in this area.
Absolutely. So there have been many studies that have looked at the cardiovascular events in patients with autoimmune rheumatic diseases. And we know that there is higher risk, but there's only been a handful of studies that have studied pregnant patients. And so we previously used the same California-based birth cohort that we used in this study to study the occurrence of acute cardiovascular events during pregnancy and postpartum in patients with rheumatic diseases compared to a reference group of pregnant women without rheumatic disease or without antiphospholipid syndrome. And so we did find that patients who have rheumatic diseases have higher risks of traditional cardiovascular risk factors and higher risks of acute cardiovascular events during pregnancy and postpartum by about 4.1-fold. This risk was higher in lupus, 6-fold, especially in those with nephritis, and APS about 13 and 18 folds respectively compared to general population of pregnant women. Most of these cardiovascular events were venous thromboembolism, about half, and the other major ones were heart failure and dysrhythmias. And also from prior literature, we know that patients with rheumatic disease have higher risks of adverse pregnancy outcomes, such as preterm birth and small for gestational age infants. And while there have been studies in mostly in the general population pregnancies that suggest that having adverse pregnancy outcome puts the mother at higher risk for future cardiovascular diseases and events, but there really, we didn't find many studies that have examined the effect of cardiovascular events on adverse outcomes, particularly in rheumatic disease pregnancies, which actually have higher risks for both cardiovascular events and of adverse pregnancy outcomes.
Okay. Well, I think you went over the aim pretty well. And I wonder if you could just outline a little bit of the methodology, such as where you got the data, exact diseases study, and the exposure of interest, I think you did, and the measurements. If you want to expand a little bit on that.
So maybe I can explain a little bit about the data source, and then Dr. Dhital can go on about the exposures and outcomes. So this is a terrific resource that we've been able to develop in California, the study of outcomes of mothers and infants, which is a linked data set of all births in California over a number of years, really dating back to the early 2000s, and with new years added as they become available. And it's linked to infant outcomes on birth certificates and death certificates, and any admissions in the first few months after delivery. And so it's an opportunity to look at population-based questions related to reproductive health and infant and maternal health in the entire state of California. So I'll pass it on to Dr. Dhital for the exposures and outcomes.
Absolutely. And so the primary exposure of interest for this was the occurrence of one or more maternal cardiovascular events during pregnancy, which were identified using ICD-9 and 10 codes for different cardiovascular events, such as myocardial infarction, stroke, heart failure, inflammatory heart diseases, dysrhythmias, and venous thromboembolism, which would incorporate DVTs and pulmonary embolism. And the primary outcomes of interest were preterm birth or small for gestational age, or either preterm birth or small for gestational age infants.
Did you get data on birth defects, or was that not part of your study?
Not a part of this study, no. But I'm not sure that we have. We probably could have identified based on ICD codes, but that's not what we looked at for this.
But you can't do everything.
Another paper.
Exactly. Yes. Yeah. As long as I get credit for the idea, that's fine.
Yes.
And so how many pregnancies were there, both patients and in the controls?
The control pregnancies, so 7 million about of control pregnancies. We looked at data from 2005 to 2020, the rheumatic disease pregnancies were about 19,000, of whom about 8,000 were lupus, 6,000 were rheumatoid arthritis, 3,000 were spondyloarthritis, and the remaining were others. And then each group were divided into whether or not they had cardiovascular events. For example, of the 19,000 rheumatic disease pregnancies, 265 or 1.4% experienced cardiovascular events during pregnancy. Mostly lupus and RA were the majority of those patients.
And in the controls, what was the rate? Remember?
It was 0.4% had maternal cardiovascular events.
And I know in your data somewhere, you discuss about the presence of antiphospholipid antibodies. I guess you didn't mention it there. Obviously, at the beginning, you mentioned it related to DVTs. I guess my question, in this data set, how good do you think that's identified as secondary? Primary, I understand. What's your, like, it's always bothered me about large data sets. How do you get a secondary diagnosis, and how happy are you that you've captured it? I believe primary is much, much easier.
I can start and I'll let Dr. Chambers add in. I think the way we could use this data set really is like identify everything just based on ICD codes.
Right.
Most of these, they are cardiovascular events as well as lupus. So the way we identified the secondary APS is really looking at, patients who had a diagnosis or ICD codes for rheumatic diseases, and additionally had a ICD code for the antiphospholipid syndrome. And so we kind of had to do it this way. It is difficult to say how accurate, because this hasn't really been validated. And, we haven't validated that in this database, kind of looking at actual patient records. I know the diagnosis of rheumatic disease using inpatient ICD codes, it's a little tricky, like the sensitivity of specificity of them. But I think the results kind of make sense, and they kind of compare to what other studies have found for like the magnitude of problems. And so I think it does make sense, but I do not know the true validity of using this particular data set.
Yeah, it's for sure a limitation in terms of being able to validate that the ICD codes were applied appropriately, that there aren't people misclassified as not having whatever the disorder is, because it wasn't recorded in pregnancy. It could have pre-existed but wasn't recorded. So there's certainly opportunities for misclassification either way. And you rightly point out, that's one of the limitations of using large data sets where you aren't able to drill down. There is, and we hope this is going to happen in the very near future, that in the state of California, that the linkage will be possible now to extend at least to Medicare covered patients in California, which is about 60% of births, which would allow us to then actually drill down into medical records for covered patients, both for things like diagnoses and when they happen, but also to be able to pull in lab values and to be able to pull in medication treatments, none of which are available in the data set that we used for this particular analysis.
Yeah, that'll be exciting when we can actually get the data that we need. That is,
absolutely.
It just struck me, lupus and DVTs, and what is it that, or cardiovascular events, because we'll stick with that. How much is intrinsic to that disease? Secondary, similar with RA, we know it occurs, but anyway, that's an aside. So yeah, want to summarize the findings and or just quickly?
Yeah. So we found that pregnant individuals with rheumatic diseases who experienced cardiovascular events during pregnancy were different from those who did not. For example, they were more likely to be Black, have public insurance, have higher cardiovascular risk factors such as hypertension, diabetes, substance use during pregnancy. And we also noted that adverse pregnancy outcomes in general were more common in pregnant patients with rheumatic diseases, for example, 26.9% compared to general population pregnancies, 15.2%. But the presence of cardiovascular events in pregnancy increased the risk of preterm birth or small for gestational age, or a composite of those modestly by 1.2 to 1.7 fold compared to pregnancies without cardiovascular events. And this is irrespective of whether or not they have rheumatic diseases or not. Just having a cardiovascular event increases the risk. And risks for some subcategories were particularly higher. For example, patients with rheumatic disease who had cardiovascular events had about 2.4 to 2.5 fold higher risk of early or moderate preterm birth, early and moderate preterm birth. And so I think even though the relative risks are modest, given that individuals with rheumatic disease experience higher frequencies of cardiovascular events in pregnancy, and they also have higher risks of adverse pregnancy outcomes, the absolute contribution of cardiovascular events becomes relevant. For example, over half of the pregnant patients with rheumatic disease had cardiovascular events, who had cardiovascular events had an adverse outcome, compared to 26.6% of those without cardiovascular events, and compared to 28% of general population pregnancies with cardiovascular events. And so I think the absolute risk increase is still important.
Yeah, it's very interesting. And we're able to determine specific events that were better or worse for pregnancy outcomes, or with numbers limiting?
So the way we studied this was we did try to classify the cardiovascular events as being a venous thromboembolism, and most of them were DVT, deep vein thrombosis, for most parts, less than 1% were PEs, from at least in the based on the codes. And so we the way we studied was looking at VTE only cardiovascular events, or non-venous thromboembolism only cardiovascular events, or both. And so both venous thromboembolism as well as non-venous thromboembolism, meaning heart failure, dysrhythmias, everything else, increased the risk of preterm birth in rheumatic disease pregnancies, but only having a venous thromboembolism event did not increase the risk for small for gestational age infants. And surprisingly, non-VTE cardiovascular events, so everything except DVTs in general, just had higher risk estimates for adverse pregnancy outcomes. For example, the highest risks for early and moderate preterm birth with non-venous thromboembolism cardiovascular event in rheumatic disease pregnancy was 5.2-fold and 3-fold higher, respectively. So just having a non-venous thromboembolism cardiovascular event. So I think most prevalent were heart failure and dysrhythmias were higher risk compared to a DVT event, which I think is not surprising.
That's quite logical.
Yes.
It's very interesting. And so, having gone over this, what's your recommendations now for the care? You've identified that now we have high risk people. Hopefully, if possible, they're delivered at high risk units. We try that, certainly in lupus, I think in most large centers. Anyway, you do deliver, and most people, again, most large centers have specific care with rheumatologists and high-risk obstetricians. So how would you care for somebody? How do you think it should change the care once you have the event
Yes.
to improve outcomes?
Yes, I could start. And I mean, I think it is, yes, like once you have an event where you talked about, and I think the concept of like cardiorheumatology clinics are getting popular these days. And I don't think they're in like many centers, but I know they're like starting in some centers, and maybe more in Canada, because I know we had a cardiovascular kind of session in ACR, which was like a lot of like Canadian, said like they talked about their like cardio room clinics, and it was really interesting. But I think that concept is important, and I think that's something that should be expanded, so we're able to treat cardiovascular events like really well in pregnancy through a joint approach. And I think what you also mentioned, but increased surveillance or increase for adverse outcomes in patients who have cardiovascular events, particularly non-venous thromboembolism event, I think is important. And also, what you already mentioned, kind of having that conversation with patients early on so that they're actually seen and delivered at a place where there's good care for the mother, as well as like provisions for the baby. Like we didn't look at that in this paper particularly, but we're doing one and we presented at ACR where we looked at lupus specifically, and having a cardiovascular event for a mom does increase the risk of like neonatal ICU admissions and things which probably are related to preterm birth and other complications. But I think just kind of having that, but I think the most important part is just including these cardiovascular risk factors in prenatal screening for the mom, so we can just make sure to treat the risk factors and identify events early and manage appropriately, I think.
Yeah, and I agree with Rashmi. I mean, the only thing I would add, and you've already alluded to this, is that in academic centers with high-risk clinics, this is likely already being attended to both preconception and during pregnancy. Maybe having a better idea of the potential magnitude of the risk is helpful, so that it's known, exactly how common this is. And then for those who are receiving care in more outlying areas, being prepared for that eventuality so that it's not a surprise, I think is important.
These again bring up these issues that come up all the time as equal access to high-level care.
Yeah.
You brought up those points. It's easy to say if you're in San Diego or Nashville or Toronto that, go see the high-risk rheumatologist with their high-risk, the pregnancy rheumatologist with their high-risk obstetricians. But when you're 400 miles from the nearest large center, it makes it pretty difficult.
Absolutely.
No kidding.
Yeah. So have we missed anything that you'd like to add for people listening?
Kind of wanted to say that, we talked about the limitations of this database, but having studies that look at like comprehensive clinical lab medication data, along with precise timing of cardiovascular events in relation to different adverse outcomes, I think would help us understand the mechanisms driving these outcomes and kind of help us explore what we could do better. So I think kind of having a sense of when. And they're probably, sometimes, yes, it is possible that the cardiovascular event caused the adverse outcome, but it's probably more likely that there's just shared or, you know, like shared pathogenic mechanisms that are driving both. And so I think just getting a sense of like just having a comprehensive data and having like a timeline and such of things would I think help us understand more.
Yeah, I think
I agree.
Yeah, I think what you said.
I'll just add.
Yeah, go ahead.
I was just going to add that, you know, so often when you publish or read a paper that involves a large data set like this that has limitations in what kinds of data are available, you can take away, oh, you know, that this is the end of the story, and it's not at all. It's sort of the beginning of the story. So it's in some ways generates hypotheses that need to be tested in other data sets that actually have that kind of data that Rashmi described.
Yeah, I think, but that's all good papers should lead to many more
Yes.
hypotheses, and that's what this is, in my opinion.
Absolutely.
You know, it's moved things forward. It's asked good questions, and I think what Rashmi was saying was very interesting. It just, the biostatisticians I know are yelling in my ear, causation, association is not causation. So as Rashmi pointed out,
right.
And there could be, you know, confounding, so many confounding things that now we're just saying, as you pointed out, the same thing that led to the cardiovascular event did something else to the developing fetus. But that's great. So we're looking forward to at least 20 more papers, Rashmi. Please. But that, I'll give you 2 years.
Me too.
I'll give you 2 years. Anyway, I want to really thank you both for taking the time to review the findings of this paper and important implications for the care of women with rheumatic disease. I think probably all women who developed a cardiovascular event during pregnancy, because you didn't make that point. And I suggest strongly to our listeners that they read the complete article titled Cardiovascular Events During Pregnancy, Implications for Adverse Pregnancy Outcomes in Individuals with Autoimmune and Rheumatic Diseases. There is also an accompanying editorial titled Cardiovascular Health and Adverse Pregnancy Outcomes in Autoimmune Rheumatic Diseases, and that's by Doctors Parimi and Ravindran from the ESIC Medical College and Hospital, Hyderabad, India, and the Center for Rheumatology, Calicut, India, respectively. And both the article that we just reviewed, as well as the editorial, are available at our website at jroom.org and will appear in the January 2025 edition of the journal. I want to thank you all for joining us and hope you'll come back next month. I want to speak to the author of an article of particular interest that I selected from the February 2025 edition of the Journal of Rheumatology. And I'd love to hear any comments from people on either X at Rheumatology or by email at manuscripts@jroom.com. And I wish everyone a good and healthy 2025. Thank you.